So it's a great privilege today to present on geriatric medicine on the Frontline. And I wanted to start simply by acknowledging the long and rich history of the PA hospital when it comes to the care of older people, but how much things have changed between what it looked like in the 50s and 60s, what the hospital looks like now, and also what our population looks like. So when the tertiary hospitals were first designed, they were designed with a single organ model in mind. So very much looking at people who presented, who were relatively robust, but came with a single problem. And increasingly over time, as our population has aged, we now have people who present with multiple problems simultaneously through the hospital. And so that has changed the way that we as a system need to address the issues of an increasing aging population. And so historically, we've broken people into boxes because that helps us as a system organise things. And so we've broken people into emergency care, where you triage and resuscitation and really decide disposition. Are they coming in or are they going out? You've then got acute care focused on the diagnosis and treatment. And then you have subacute care where people recover or re-enablement. And traditionally, that has been where geriatrics has sat. As we have developed as a more complex health system, and as our population has got older, more multimorbid, geriatrics has moved more into the acute setting. And so we already have established orthogeriatrics models, which are well evidence-based and very effective, and extending into other perioperative areas. It's analogous to really what we have discovered in the literature in terms of acute stroke units, which are multidisciplinary, focused on function from the front door, not just the medical issues, and that have excellent and unimpeachable data in terms of their impact on patient care. And then we've got newer models coming through in terms of things like partnerships where you bring geriatric knowledge and geriatric skill and understanding alongside other specialties. So oncogeriatrics is a growing area of interest and development, and geriatric trauma. And I know there is a unit in Melbourne that's doing some really great work in that space. And so what we've done is we've pulled the acute and the subacute together. So instead of working in series, doing one and then the other, we can work in parallel and do both of these aspects of care simultaneously. And here at the PA, we have a very well-established orthogeriatrics unit. We also have an expansion more recently into perioperative medicine with the addition of Aisling Fleury as a new geriatrician who is working specifically in this space. And we also have another acute model, which is the cognitive support unit, which is recently opened here, which is a standalone acute geriatrics unit targeting people with dementia and delirium. And so now that we have, I think, quite well established that geriatrics has a role in the acute setting, my thesis is that it also has a role in the emergency setting. And that we should be bringing all three of these aspects of care and aligning and starting all of them from the door. And we know that the geriatric skills in terms of frailty and an understanding of function, in terms of the ability to balance the competing interests of someone with multimorbidity, with a particular level of skill and knowledge in dementia and delirium, and also the systems knowledge of both aged care and the systems understanding of the community supports for an older person and what it is that they can access. All of these things are incredibly useful to bring to the patient in the emergency department. And when I'm saying geriatrics, and I should have said this at the outline, I'm not just talking about geriatricians, I'm talking about geriatrically trained clinicians. So nurses, allied health, pharmacists, doctors. Bringing that skill set across the continuum is really useful and important in the acute space to bring this together. At the PA, we already have quite a bit of this. So we have allied health in our ED, we have Care Pact, nurse that does nursing assessment, and we have a Jedi nurse that does geriatric nursing assessments for the community dwelling. And really what we've added in terms of my role is medicine. And so an ability to make more diagnostic and treatment decisions off the basis of that information. And so I have a couple of stories that I was going to tell today about the type of patients that I've seen. The first was a lady in her 90s from a nursing home who'd presented a couple of weeks previously with digoxin toxicity in the setting of worsening renal failure. And so she'd gone home. It was also discovered at the time that she couldn't have a beta blocker because she had very severe aortic stenosis. And so her medications were adjusted, her digoxin dose was reduced, she was returned to the nursing home, and then I met her on the ramp into the emergency department where she had rapid AF. And she was running at about 130 beats per minute, which in a 91-year-old lady with a clinical frailty scale of 7 is fast, is actually very fast. So it doesn't actually flick in the general OBS chart of the hospital. So anything above 130 is seen as a significant tachycardia that requires immediate response. But because she was sitting just below that line, her need was not identified even though it was clear. And so because of my geriatric eye and skill, I was able to bring to her, now I couldn't bring her any faster into the department. We had to wait for a bed. What I was able to bring her, two things. One was digoxin. And so clearly her dose had been reduced too far and she needed a top up. So I gave her a loading dose of digoxin on the ramp so that by the time she got into the department, that would have had a little time to work. We would have slowed her down a bit and we could move her management forward. And the second thing I got was a pillow because she was uncomfortable and trying as best as possible to manage her physical comfort in the hospital to reduce delirium and simply to make her better. The second lady, I had to think about a minute what the Willy Walker stood for. The second person was an elderly lady, 97, living in an independent living unit. She'd been there 10 years. She was very well supported, and it was one of those retirement villages where you've got a nurse on site. And she came with a fall. She was not sick, she was not injured, but her mobility was shockingly bad. And the physio just went, oh, that's terrible. And so the emergency department were heading towards an admission because she had, inverted commas, failed physio. And when I came to see her with the excellent assessment that had already been done by the Jedi nurse who had spoken to the family, who had absolutely promised her that they wouldn't send her to a nursing home. And more importantly, they had spoken to the care provider who said, we love her, we care for her, we stretch. Yes, her mobility is terrible, but we are prepared to continue to support her. And so really, again, we did a postural blood pressure to make sure that her antihypertensive wasn't contributing to her falls, which it was not. And then really I just gave advice and support to the emergency department to send her home because coming into hospital was not going to change her mobility. In fact, all we would do is make it worse. And that this was really an acknowledgement of the dignity of risk of an older person and their family living in an environment where if she goes to a nursing home, it's not going to stop her falling. She'll just be found a little sooner, but she and her family had made the choices. Her care provider was happy. And so this was the ability to support a risky discharge. And she went home. And then the third person is actually a person I met this morning, Bob. And so Bob was found on the street by a lady who noticed him just wandering up and down looking a little bit lost. And when she spoke to him, he couldn't remember his address. And so she called the ambulance and he came to hospital. And he'd had a full delirium workup, CT scan, bloods, chest x-ray, ECGs, all of which were pristine. Bob did not have an acute illness. It was very, very clear that Bob had an undiagnosed dementia. And so there was no collateral. He didn't have a phone. There was no family members. The ED weren't able to get on to anyone to get any idea of how safe Bob was. And so the plan had been for a medical admission. And with discussion with me, the Jedi nurse did a little bit more digging. And what we first of all observed is that Bob was really well put together. He had no signs of struggling from a function point of view. His clothes were well laundered. His glasses were clean. He had his cards in his wallet appropriately sorted. And yes, he had a little bit of trouble remembering the exact details of his address, but he could clearly explain where he was going. And then the Jedi nurse discovered that he was turning up regularly to his GP. He was filling his scripts. And then he gave us the details of a friend of his who he'd meet 3 times a week at the casino and always turned up on time, always knew what was happening. And so we felt comfortable that Bob didn't need an admission, but what he did need was a dementia diagnosis and a look into, as his cognition continues to worsen, what can we do to honour his wish to be at home? And so we referred him to the amazing service Gemeth, who accepted him and would see him the following day in the community to follow up in terms of the formalisation of the dementia diagnosis and the setting up of further services for Bob. So what I guess I'm saying is that there is a lot of work to be done by all of us, and that a partnership model between geriatrics and the emergency department has great potential to improve the care of older people, to reduce unnecessary hospitalisations, and to improve the trajectory and the journey of a population that is only going to get older and more complex as we go. And so it is a great delight for me to step aside now and to hand over the microphone to an expert in this area, Professor Rockwood.
Symptoms of dementia, but sometimes it's called responsive behavior, and sometimes it's just plain disturbing. Anyway, whatever it is, it's maybe delirium, but it's probably complicating underlying dementia. It's probably a UTI. On the other hand, it could be a social dementia. So that's their differential diagnosis, and they're just about to share their view about futility and ask the nurses why they're doing all these things. When he sees the guy who's just handed over to him back in the emergency department in his vacation clothes, who says, "What's happened to Bob?" My guy's called Bob too, it turns out. So if we think back about what the conclusion they come to, it's not wrong. The pretest probability of someone over the age of 80 having dementia is high. If they're in a hospital calling out, then it could well be BSPD. The resident actually did think about delirium complicating dementia. But what has happened to Bob? Why did the attending physician ask what's happened to Bob at a glance? Because the attending physician knows Bob well. Bob is from the same small community where this person grew up. He knew him as a grown-up when he was just a wee boy. And he saw when Bob came back to retire back to the community after being a big success up in Toronto, which is like as big in the world as it gets. And he helped Bob look after Bob's wife, who had dementia and who died a bit ago. And during the whole time that Bob was the sole caregiver for his wife, Bob's only respite was in the morning around 5:30, 6 o'clock. He'd get up and go for a run. And he's about the only 80-year-old in Smallville going for a run at that hour. And what Bob was famous for, because it's a small community, famous for anything at all, but what Bob was famous for was not just the story of being the rich guy and the dedicated man and so on, is that he would end his run every morning by booting up the hill. He would come to the base of the hill and just run up that hill halfway up to where his house was. And the community took a certain pride in it. I mean, when people talk about it, they somehow imagined they were the ones who were doing the run up the hill. But everybody knew that that was Bob. So this is Bob's pre-morbid state. And there's a big delta between Bob running up the hill and Bob confused. And part of the ruckus that the resident heard was that one of Bob's neighbors was driving by the park across from where Bob lives, and he saw Bob out there, and he could tell at a glance, there's something bad going on here. And so he went over, saw it was Bob. Bob didn't know who he was. He put him in his pickup truck, booted up the hill further up to the hospital, pulled into the parking lot, as you say in Newfoundland where I'm from, burn up the horn. And that's what the start of the whole ruckus was, because in that small community, if something really bad was going on, that's what you did, because it would take 40 minutes for the ambulance to get there sometimes. So you just moved them there. And so people came out and everybody knew it was Bob. And so that's why the nurses were putting the IVs and all this other stuff was going on, because they knew Bob was ill. Turns out the resident was right, sort of. Bob had urosepsis and he was shocking, but he was dealt with promptly and quickly. He was stabilized. He was sent off to the main fancy hospital an hour away. And he was there for about 10 days, came back, spent a day or two in the hospital, and 3 months after was out and back doing his Bob-like things again. So this gap between Bob is an 84-year-old fit guy, and Bob is not one of the half of the people or thereabouts with dementia. This variable aging, that is called frailty. That's where the term came about in the modern era. In 1979, used an actuarial journal to talk about variability and the risk of an adverse outcome for people with the same degree of exposure. Originally, variability and the risk of death are people of the same age, subsequently taken up particularly by the cancer crowd for the variability in mortality for people the same degree of a cancer staging. And a lot of fancy math was done around that, and it was a powerful concept, so much so that it took to 2008, if you were to type frailty into PubMed, that didn't come up first. Frailty happens because it's more or less rapid aging, and it occurs when deficits go unremoved or when damage goes unremoved or unrepaired to give rise to a health deficit. And by the way that we do it, because there's two ways to do frailty. One is as a specific phenotype of weight loss and shrinkage and slowness and decreased activity and exhaustion, or the way that we do it, which is we count the number of things people have wrong with them, divide by the number of things that we counted, and that's called a frailty index. So 75, how does that come into it? Well, this on the x-axis is age, on the y-axis is the cumulative risk of getting dementia. This is in Canada. I'm showing Canadian data because generally we have Americans come talk to us showing American data. I'm showing Canadian data. So at age 75, the risk of dementia really starts to take off. This is data from Sweden, from the Swedish Fracture Registry, life course, and it shows the risk of fracture. Blue in boys, red in girls, blue in males, red in females. But you can see, it doesn't matter what you are, it goes up at the age 75. This is the incidence of end-stage kidney disease in Canada. That goes up too. I'm going to stop now because we go a whack of the diseases of old age, and they mostly all take up at age 75. A really important question, something that the physics of frailty group that I'm with is spending a lot of time trying to figure out what's going on at that age that makes this such a consistent feature. So as I was saying, the way that we do frailty is we count the number of things someone has wrong with them, divide by the number of things that we counted. So people say, what do you mean divide by the number of things that we count? Well, you're going to count, you have to count in a database. And the database doesn't have everything in the world in it. It has the things that the people who put that database together, typically an epidemiological survey, but sometimes even a healthcare record, they put things in that were relevant to them. And so we count things that are deficits, which is a health attribute that's associated with age, and that is bad for you. So if left-handedness is bad for you, and as far as I know it's not, we wouldn't count it because it is not associated with age. If white hair was bad for you, and as far as I know, it's not. In fact, it gives you this appearance of unmerited authority. So it's okay, but we don't count that either because it's, even though it increases the age, not bad for you. So on the x-axis is age, on the y-axis is the degree of frailty. The black line is the average frailty index. And you can see that it goes up with age. That's the first thing that we discovered. Yeah, no, that wasn't much of a discovery at all. The discoveries didn't happen till we realized this. This is variability in the degree of frailty, and it goes up at a certain age. It really takes off at a certain age. Anyone want to guess what that age is? 75, they said, is one. Yes, and they were all correct. So what we've then done is to look at the ways in which the outward and visible signs of a person aging change over the life course, and they change over age. And it turns out because people age variably, they change more clearly in relation to the degree of frailty, not in relation to the age. So on the left is Bob, as fit as he can get. And you notice as fit as he can get, he doesn't have the big kick going on. I noticed that, I think it was Sydney redid the icons for the clinical frailty scale, and they've got someone who's like, the wind is blowing by, he's going so fast. No, Bob's got not a great kick, but he's out running. He's got a bit of haunch on him, but he's out running, right? That's the important thing. That's what aging at 80, successful aging 84 looks like. The woman also age 84 who's in bed is very severely frail. She's in the act of dying, not on the cancer plan, just on the gradually, undramatically, slowly slipping away plan that goes with advanced frailty. The dilemma we've got in the emergency department is that any old person can look like the woman there, particularly if they've been in the emergency all night and the lights have been on and they haven't had a chance to pee properly and God knows what else is going on. They can all look like that. That's why we can't just look at them, what they're like in emerge and say, oh, that's what they're like. We have to figure out what they're like at baseline. And believe it or not, that easy thing to do hardly ever gets done with any degree of accuracy, except by people who know how to ask the questions and go after it. And that's one of the big things that geriatrics brings to bear. Believe it or not, we can understand the baseline state. So as we're trying to figure out how all of this works and what we should include in the order in which people lose function and whatever else they lose, we looked at mobility and balance. Why is that? Because we as humans have evolved to have upright bipedal ambulation, opposable thumbs, divided attention, and social engagement. So unsurprisingly, the geriatric giants, a term that means the way in which someone is telling you that they're ill without saying I'm ill, are falling or taking to bed. That's the decline in upright bipedal ambulation. Functional decline, the opposable thumbs. Delirium, dementia, the divided attention. And social abandonment, not rarely, the failure of social engagement. So let's just take mobility and balance as an example. So on the x-axis is a frailty index based on a comprehensive geriatric assessment, which as far as we know is the best frailty index that you can have. And on the y-axis is the cumulative distribution. And the dotted lines are the lines of people who've got impairment. And you can see they shift. It's not just the impairment in mobility. Everything shifts over. The impairment in the mobility is reflecting underlying problem they've got with integrating all of these functions. Non-specificity of the sign is its great power. And you can do it something fancy with a timed up and go. You can do a functional reach test, and you got, meter sticks and various things and whatnot very precisely. You can also get it by history of falls. You can also get it by looking at how someone walks and seeing they've got a characteristic gait of old age. And however you do it, impaired mobility is going to be an important part of frailty. So that's why the clinical frailty scale incorporates that in impaired function and such. So here's a bunch of people all aged 84. The variation in the size is the variation in how commonly they occur in the population. And you could take the bob-line and squat it down to it that big because you hardly ever see very fit people in their 80s in the hospital. They exist, but it's not very common. So the clinical frailty scale is this thing that we've got the copyright on that we made freely available, and it's used all around the world. And it just grades people from very fit and on through to terminally ill. So I'll take you through a few of these things right now. So this is about as good as it gets for the fittest group of people you see in the hospital. At baseline, they're managing well. They may have symptoms that are a bit symptomatic. They'll feel that they're not quite as fit as they would like to be, but they're still doing quite well. But they're not regularly active beyond routine walking. Living with very mild frailty is the next thing. You notice I've got two icons in there now because we had too many people looking at the picture and then looking at the person in front of them and not reading anything and saying they're that frail, right? Like not even asking the question, well, what did they look like 2 weeks ago? Just they're that frail. So very mild frailty is the earliest marker of impending dependence. And the story that I tell is that the place in Newfoundland I come from, when I was a boy, it snowed a lot. And one of the ways you could tell someone was getting to be a bit older was when a man getting to be a bit older was when he wouldn't go up on the roof during the winter, put the ladder up, take his shovel, go up on the roof and shovel snow off the roof. Because there'd come a point at about 2 feet worth of snow where you already have some pretty good roof, but get beyond that, it's going to cave in. So it was a sign. And it was known as a sign, right? Did you hear that Uncle Jim? Did you hear that Billy had to go up and shovel the snow off the roof? Uncle Jim, he's getting up there, And it was just a sign. So we don't have that as one of the standard tests. But what we find is that symptoms are limiting activities, and they're very mildly frail. And commonly they'll feel slowed up, although I gotta say slowed down here, but in any event, they're slowed up, being tired during the day, and that's their state at baseline. And those of you who know in detail the other way, the syndromic way, will notice that this person meets the criteria for frailty according to that way. Then there's very mild frailty, where you start to have impairment first with the instrumental activities of daily living. The very severe frailty, where you've got the personal activities of daily living. In 6, your IADL impaired. You've graduated from that into moderate, but not to severe. You can still do your personal activities as long as you've got some set up. In dementia, one of the characteristic things is someone has to lay out the clothes for the individual to get them to change their clothes. And the dementia staging and the frailty staging at this level are about the same, and not by coincidence. So against that background, let's think about this, how frailty impacts mortality in patients in the emergency department. So these are data from a bunch of people that I saw when I was doing the consult service and Emerge. And so I wonder if people can see this on the screen. You can see it, but you can see it on your screen. Okay, fantastic. So look, low severity, high severity. 30-day mortality in blue, 6 months mortality in red. Low degree of frailty, high degree of frailty, low degree of frailty, high degree of frailty. So here's Bob. And Bob at CFS 1 to 3, in the series that we did, no one died. So yeah, we got an immortal outcome. Well, at least they didn't die within 30 days. It took them to get 6 months before any of them died. And so you can see that clearly at a glance. Acute illness is bad for you, but so is the degree of frailty. So if we go back to Bob, and we were to stand next to Dr. Madeup and say, let's kind of reframe your words now. Confused, delirious. That's what you mean. Yeah, and he can't walk, impaired mobility and balance. And disheveled, smelly, functional decline. Plus or minus incontinence, but I'm not a big guy on the incontinence end of things. But look back to our folks now, and look now if we draw this out with Kaplan-Meier curves, and the dotted line is the acute illness, and the straight line, or the smooth, the filled in line, is the person who wasn't triaged as a high level of acuity. So clearly, it's bad to have a high degree of frailty, CFS 7 to 9, and come in acutely unwell. And it's not quite so bad, or it's actually okay if you're just sick. But here's what I want to draw to your attention. A lot of stuff is going on early. These curves drop down early, right? People get sick and it's bad for them and they can die. And that's where 72 comes from. We have 72 hours to get things starting to turn around, get function turned around, get mobility turned around, get dehydration sorted out, get the electrolytes looking like we have some grasp of what's going on, made better if the people who are prescribing the electrolytes have some understanding of how the kidneys work and such. So this is one of the major failings that we see as geriatricians. I'm sure the general interns see it too. You look at it and say, well, I'm not sure who prescribed what IV fluids for this person, but it was not anyone who apparently knows about what a kidney does. So there's lots of things you have to get right. Lots of things you have to get right. And it's not that they're going to tie into one big thing. Patients who are frail and sick have many things wrong all at once. That's not a bug, that's a feature. That's what makes them frail. And we have to have systems that allow that to happen. And the dilemma in a hospital in which we have really, really good subspecialty services, which, thank God we need them, is, those damaged lungs, they come in a person. That bad heart, there's a person that package comes in. And we can't expect just to do the one thing with the heart. Well, can't say that anymore because cardiology, you can't do one thing with the chamber that you're interested in, and the valve versus dysrhythmia, the part of the chamber, the way you're interested in, and think that everything else is going to be fine. And if it's not fine, it's not the patient's fault, right? If you're working in a system that has prize and give you high fives and so on, your generalist skills have gone away, you got to have someone working with you who can do it, who can help you with that. And it's not going to help if the person you're working with, you go, I've got the part of the thing done now, right? You have to have teamwork. And so these are the things that we have to accept. And that's why there's a role for geriatrics as the pointy end of care. And one of the ways we know we've got 72 hours comes from work that Ruth Hubbard was involved in way back in 2010, published in 2011. And it was this really nice study in which we looked at how older people moved in bed when they were ill. We looked at bed mobility. We looked at the mobilities and how they got out of the bed. We looked at the mobility once they were up and moved. But much of the signal in the first 72 hours comes from how they move in bed. So geriatricians, we know how to grade good bed mobility from bad, we and the physios. Well, other people know too, but we actually put numbers on. And we learn to pay attention to those. We learn to pay attention to the small changes that it makes in terms of someone's prognosis. The early treatment response, the ability to go from being able to get your arm across your chest when you're being asked to sit up to holding on the bed and starting to pull, that's huge. That's a big vista. You've made huge progress, but you got to know how to look for those things. And then what other things should go with that if that was true, not some magic fluke. They did everything that they could do for that one grasp. So there are things like that that sound like nothing, but they're everything in terms of prognosis. If it was a blood test, we'd all be talking about it all the time. It'd be like ultra, super, highly sensitive troponin. And you have to have it every 10 minutes, and then you phone cardiology every minute. So it's this early period. That's why the early period mapped to the early mortality period, because that's when all the bad things are happening, and we don't have a lot of time to turn it around. And it's physics, it's entropy. It doesn't matter to the patient's body. Well, we're not going to count the first 2 days. I didn't get to the emergency department the first 2 days. No, we're counting all of it, right? So we've got to get really good at the frail older adult and emerge. They need to be seen as high priority if we think we've got a chance to get them out. So let me put some numbers on this. This is from Ruth's paper. The ambient mortality of patients over the age of 65 admitted to the medical teaching units at our hospital back then was 5%. And that's what we saw if their mobility and balance got better in the first 72 hours, because that's mostly what happens when people don't die. They're getting better, and they're getting better early. But look what it was if their mobility and balance got worse in those first 72 hours. 74% of those people were dead at 30 days. So we got to pay careful attention to this. And it turns out, in some ways, this is fixable. Here are some data from an intervention trial, a fairly small sample size, but you didn't need a big sample size for this to be true. So green is better, and blue is the same, and yellow is worse. And this side is the intervention side, and this side is the control side. You can tell at a glance, it's better to have been in the intervention side than not, right? So it looks like some part of this is remediable if we can get on it with elegant quickness. I've got some data about early mobilization that I want to share with you now. And everybody who has been part of our early mobilization program has heard a condensed version of what I've just told you. And they've had, across the province, people, I've done it, other folks have done it. We come and say to them when they're doing, this is great what you're doing, and here's how I use the words that we talk about here for this. And in the early mobilization, we set it all up in such a way that we're trying to avoid what happened at the hospitals where I work, which is nothing's going on. Day 3, let's talk to physio. And then hopefully it's not a Friday and physio gets to assess someone straight away. So over half of the consults through the early mobilization program, and half times that early mobilization people were called, they were called by rehab. We failed in that. We didn't get to them in the first 3 days. So change is really, really hard. And even though you do all the stuff, had the groups met and found out the names and talked to everybody and made sure that everyone was felt safe with all of this, the ingrained attitude in the wards was that I, as a nurse, cannot tell whether the person is safe to get up, but physio can. So let me talk to physio first. And physio can't do it at a glance. They got to do their whole assessment. So early mobilization allows us to begin more widespread use of the clinical frailty scale, because the hospital that I work at, we didn't use the clinical frailty scale. We didn't use any scale until certain things happened. being COVID, and then the need to get on with this became very clear. And we targeted the program entry at CFS 4 to 6. So everybody had to know what 1, 2, and 3 were because they weren't eligible because they were too good. And everyone had to know what 7, 8, 9 were, and they weren't eligible because they were too bad. And what happened was, it's not that everybody did it 30% of the time. Some people did it 85% of the time. Some people hardly ever did it at all unless they were forced to. And so we found that the places that were the early adopters were able to get on with mobilization better. And we're still in the process of crunching all the data. And hopefully they also had the better outcomes. And hopefully we'll go from fear of doing to fear of missing out, and we'll go with that. And the other thing we're doing right now is trying to find a way to allow the mobilization aides who don't have they've got all the training they need, but they're not a profession. So someone somewhere has ruled at a very high level that they can't tell the nurse that the patient they're looking after has been mobilized in the last 2 days can't get out of bed now, or is more confused or something, even though, as I tried to explain to them, you wouldn't tell them on a surgical ward. They couldn't go tell someone the patient just thrown up blood everywhere, would you? Right? But people don't see that as being important. Throwing up blood, definitely important. Suddenly confused, they're old. What do you expect? I expect them to get better because that's how it works. If they're getting better, that should continue. So I'm making no bones about it. We're trying our hardest to make these changes, and change is very hard. But 72 is the number that we have for that to happen, 72 hours, and we're trying to beat away at that. So what about 5? So I am told that here in Brizzy, like the rest of Australia, like every part of North America, internal medicine residents are taught to come up with a problem list, line them all up, and to soak the notes, subjective, objective assessment plan. And 5 is the number of those things you can write down in a patient before one of them inevitably contradicts something else in what's gone above. And if it's clinical practice guidelines, probably get to 3 before you're going to make sure that they're at odds with each other. So the way we handle it in geriatrics is we look at how any intervention we're going to have is going to impact cognition, function, mobility and balance, and social engagement. And we can referee things through that. And then the contradictions kind of melt away when you start to work your way through how are you going to achieve the best with all of these things done. So 5 is a magic number from the geriatrician standpoint. And the other thing is, as we start to know these things, we've got the guts of a comprehensive geriatric assessment, and CGA is our major technology. It's the thing that we have done in geriatrics that has been the most effective, even up trials from reported this year, reported in 2024 in Lancet Healthy and Longevity about a CGA intervention in an emergency department in Ireland, to 2022, the landmark studies, 2022, 2023, the landmark studies with orthogeriatrics and such. CGA is at the heart of what we do. And so we need to have a way to have CGA become banal and unexceptional, not something you've got to go have a geriatrician themselves spend 2 hours themselves on. So it's for prognosis. That's a small part. Is for the care plan. And that's why CGA is so powerful. It's not the assessment, it's the care plan, the individualized care plan, the thing that worked for this patient. Care plan, why do you know that? Because you've gone through the negotiation with the main caregiver at home to make sure that what you're driving for and what that person needs align in some ways. And if not, you're trying your best to make it align. All those messy parts of what you need to have successful discharge of the patients. And the final number is 80-20. 80-20 is, if you've got a really good team, any member of that team should be able to answer 80% of the questions the family bring up themselves, because they've been around, they've seen it done. If the doctors hear this, what they would say, and such. And 20% of the time, though, you're going to have very specialized knowledge. You don't believe it? The physician's there. You don't believe it? Well, of course you do, because specialized knowledge is how you make your living. But say for a minute you suspended your belief in that. Someone asks about nutrition, and ooh, let's talk to the dietitian. One of the things that we've encountered is the very widespread risk intolerance that has been baked into a lot of the training for some years. And so we're countering this with a program called the Dignity of Risk, developed by a social worker and an occupational therapist at the hospital where I work. And Dignity of Risk allows people to understand that a safety culture, safety first culture, though it sounds great and is baked into administrative lore, is not the best way to deliver care, because risk aversion will kill people more surely than taking risks will. And that's what the data on mobilization show. One of the things that we encountered in the hospitals that were late adopters was fear of falling. What if they fell? What if they fell and broke their hip? What if they fell and broke their hip and died? What if they fell and broke their hip and died? And then we get sued. Okay? So that's a realistic fear if you watch a lot of American TV, but the data from Canada suggests that is not a realistic fear at all. And what we're seeing coming out of the United States, God forbid, is that people are being sued because patients were poorly mobilized, and that's where the big push to rehab hospitals and such. So we have a whole teaching program on this. It's a half day one. We make it widely available. It's probably on the interwebs. And we have found that one of the best audiences we had for it was the senior administration of the hospital. And it made an impact there that has been very helpful. And so then we take people through what barriers to the dignity of risk. So allowing the person to live at risk. So Bob, right? Bob was able to go back home. It's a better place for him, and it's where Bob wanted to be. And his ability to articulate all of that would have been difficult, but you could have definitely structured a conversation that would have given him the opportunity to opt out. That's a skill, right? That's part of the skill set that we have on offer. So I'm going to sum up by saying the four numbers: age 75, that's when all diseases of aging take off and people have more than one thing wrong at a time for the most part. 72 is the number of hours you have to turn around acute illness in an older person that comes to the hospital. 5 is where the benefit of soaping the notes is supplanted by the harm of doing that. And 80-20 are the things that everyone on the team should be able to share. So our group right now, and I have a job to run a thing called the Frailty and Elder Care Network for the province. So it's an administrative job in 20% of my time. And what we're trying to do there is to develop the tools that we need. So we're looking at scalable passive measures of frailty. We're looking to introduce a thing called primary care geriatrics, with primary care geriatric assessment. We're trying to get the comprehensive geriatric assessment, the use of that to be more widespread. And I tell people you can read a CGA like you can read an ECG. And just in the same way, they don't expect the cardiologists themselves to go and take the ECG. We should have people gathering the information that needs to go into the CGA. And we're tackling the ocean of frailty hostile culture in some of the places that we've been by a steady drip of better methods, attitudes, audits for outcomes. And I think that one of the ways this is going to succeed is we're going to need specialties like geriatric cardiology or geriatric nephrology. Now, I don't know what it's like in Brizzy. I don't know what it's like in Australia, but I know in Halifax, if you get the cardiologist on side, things will be a lot easier for you, right? And I have self-consciously modeled a lot of the examples I've got. You can read CGA like you read ECG, probably like you read an echo, much higher fee for that. We don't expect the cardiologist to do the ECGs themselves. I self-consciously have tried to model myself on how what they do is worthwhile. So the final summary is that you take away only one thing from this. Don't say frail, not frail. There are grades of frailty, and the grades make a huge difference. Frailty is a complex state. You can't look at it and do one thing and fix the entire bit. It requires coordinated, multidisciplinary teamwork. It's a team sport, is geriatrics and frailty care. And that really, 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 we should skill ourselves up to make sure we've got a really refined understanding of what the early response to treatment looks like for our patients, for our treatments, and use that as something that can help guide our understanding of how to offer promises to families that we can keep. I would like to thank all of these people who've done the funding and been colleagues and students. I'd like to thank all of them for everything that they've done. I'd like to thank you for listening. Thank you very much.